in between, I would like to thank every single one of you for taking the time this afternoon, I'm sure it's beautiful in Cyprus, to watch this lecture. It all started a number of years ago. After spending a few years for military training, as well as a refugee camp before, I found myself in SW17, what we call Tooting and Blackshire Road, where this place is. And to them, I owe my life. They welcome me with open arms. I don't know if you know where this place is, but usually the medical schools were in the center of London. This was far outside, traditionally an infectious diseases unit, where mainly was TB, and the graveyard across Blackshire Road was there to tell the story. But that place felt like paradise for me, having left Cyprus. In the process, I had a number of degrees. All the degrees belonged to St. George's Medical School, who I dedicated to. For me, the experience of being there was more than enough. My career structure, if I can have the second slide, included 6 years of training with a BSc in clinical pharmacology sponsored by ICI. Then after finishing that, I've done my house jobs locally in Southwest 17. And then I was offered a job as a registrar in medicine stroke cardiology. In 1995, I was asked to join the elite troops of cardiology. And that was really the creme de la creme situation in London at the time. Only 2 major units, St. Bartholomew's and St. George's. And I was privileged enough to be offered the last senior registrar post in cardiology, only 19 in the country, now obsolete. In 2000, I was given the offer to go and work in King's College Hospital, in particular Lewisham, which was an experience and a half. And then I was made an offer to join Frimley Health and NHS Trust. At the time, it was Wexham Park Hospital. I was also made a senior lecturer at the Brompton and the Harefield NHS Trust, both part of the Imperial College School of Medicine. If I can have the next slide, please. My career included 30 years of training junior medical doctors. Is something I would love to do in Cyprus. 30 years of training MSc fellows, 20 years of supervising PhD and MD fellows. And as part of my training, I became a council member of the postgraduate medicine. But where we begin? Let's have the next slide, George, if I may. These are all the professors, the galaxy of professorial talent. You may recognize some of them that I happen to work either clinically or academically. To them, I owe my life as well. It's interesting, the clinical expertise that we had was exceptional. You may recognize some names, Professor Brian Robinson, John Camp, Professor McGregor. And I dedicate this lecture to them as well. If I can have the next slide. My academic career started on a medical ward, Addison Ward, in St. George's, with the following finding. The top, I don't know if you recognize it, is what we call a non-selective aortogram. We're dealing with tubes. In the middle is the big vessel called the aorta. There is a ring there, that's the pigtail catheter, positioned inferior to the superior mesenteric artery. There is contrast going in the areole position, outlining the renal arteries, one on one, one on the other side. And that essentially was a normal investigation called normal renal arteries. My other half, who is a child psychiatrist, you're tutoring child psychiatry, thinks I'm a plumber, and plumber I am, as we deal with tubes all day long, opening them up, putting stents, etc. And then I'm faced in 1995 with a lady on Cheselden Ward, bed number 3, who was not able to tolerate a large number of antihypertensive drugs. And then she told me, typically in a rather sort of Cockney accent, doctor, your medicines aren't going to work. And of course they didn't. In that situation, we were faced with a patient not willing to take any more medicines, and we knew that we have to do something about it. And in this situation, the biochemistry did not suggest primary hyperaldosteronism, so we cut the corners, we went straight for the jugular, we went for a selective renal angiogram, and on the left, you can see this typical appearance, what we call fibromuscular dysplasia, a corkscrew appearance, which itself can cause hypertension. Just making a small parenthesis here, this hypertension is by far the biggest cause of premature cardiovascular disease. The majority of the patients have essential hypertension, no obvious cause found, but a small number of patients have secondary conditions, in particular, in this case, renal artery stenosis. And the fibromuscular dysplasia is the condition that can potentially be treated with sparing the patients from medication, which is usually very expensive and uniformly and not being able to tolerate it. So this patient had angioplasty to the right renal artery, and the patient's blood pressure normalized and no medication was required. We did a study and we confirmed that, so it's important to pick it up. And we will describe a few modalities later on. On the right side of your screen is the other type of renal artery stenosis, and this is called Atheromatous renal artery stenosis. In the middle, the aorta looks racketed. There is a lot of atheroma in the aorta, and the proximal right renal artery on the left, you can see a severe proximal stenosis with poststenotic dilatation. The main problem with this is if the stenosis is bilateral and it occludes, then can lead to end-stage renal failure. Secondly, it's a cause of hypertension, and as we will see very shortly, recurrent pulmonary edema or congestive cardiac failure. And it's important to treat it, to recognize it, and essentially treat it. Let's go for the next slide, please. This is a common from the 1990s. This is what we call a dry gangrene, and the patient had high blood pressure, hyperlipidemia, was a smoker, and developed this scenario. Also, the patient was diabetic. And on the right side of your screen, you see the appearances of significant aortoiliac disease. The renal artery is narrow, the aorta is dilated, it's aneurysmal, the bilateral iliac vessels and their branches are also significantly narrowed. This condition presents as peripheral vascular disease, intermittent claudication, pain in the calves or the buttocks when they walk, a syndrome called Laric syndrome. And this condition essentially was very prevalent. And we have done a big study looking at the patients with peripheral vascular disease, and we noted that 4 out of 10 patients with intermittent claudication and peripheral vascular disease who had their aorta looked at, they had significant renal artery stenosis. Okay, this was known, but what was not known is that if you operate on these patients, if you undergo revascularization in the form of surgical reconstruction, a large number of them died in the perioperative period from either strokes or heart attacks. And it is then that we coined the word atheromatous load. It's no good looking at the aorta. You have to look at the heart and the carotids. I'll come back to this in a second. So this was a major publication at the time. We were working together with John Dormandy and Mr. Taylor, both extremely capable surgeons, and it's something that, of course, has changed the practice of vascular disease in the UK at the time. Can I have the next slide, please? Okay, this is another slide essentially highlighting what I already sort of mentioned. On the left, you see a non-selective aortogram showing significant stenosis of one renal artery with poststenotic dilatation, so does the other as well. Significant aneurysmal disease, multiple sequential aneurysms in the aorta, infrarenal aorta. In addition, we also looked at the carotids of this patient, and we found that on the panel A, there is significant external carotid artery disease. So it's important to see the patient as a whole rather than just the sort of abdomen. And the surgeons at the time were very surprised to really find out that their patients were dying from heart attacks and strokes, and they should have looked at the aorta, coronaries, and carotid vessels in the meantime. Next patient, please. And of course, there was a great interest at the time in genetic factors associated with cardiovascular disease. In particular, the angiotensin converting enzyme genetic material, essentially the HD polymorphism. There was an association between that and coronary artery disease, as well as coronary stenosis after stenting. We have also shown that this HD polymorphism, the DDD, is responsible for renal artery stenosis as well. So we have confirmed that the ACE polymorphism is essentially responsible for cardiovascular disease rather than only coronary disease. Could I have my next slide, please? What do you do about it? This is a 51-year-old police officer presented with intermittent claudication to the surgeons. And you can see the iliac vessels significantly narrowed. You can see the arrows A and B, and also renal artery stenosis as well, highlighting the information we already outlined. The patient did not like to face the surgeons. And of course, we had very little option but to use at the time what we call statins or HMG coactase inhibitors. It was at the time when atorvastatin was first became available in the mid-1990s. And you see that after 6 months of being on atorvastatin, bringing down the cholesterol significantly, you can see a regression, that is clearing of the atheroma in the renal arteries where the arrow is, and also in the peripheral vessels. For the first time, we have proven that statins work and can regress, not only stabilize, but can dissolve the atheroma altogether. So anyone who doesn't believe in statins, this is the evidence. Pre and post statin, significant reduction in the atheromatous load. And the patient, of course, became much better and was very grateful not sending him to the surgeons in the first place. Can I have my next slide, please? And this was the real patient that really made a difference. 60-year-old gentleman on Addison ward, St. James's Wing, presents with congestive cardiac failure, raised jugular venous pressure, peripheral edemasitis, with elevated blood pressure at around 180 over 102 millimeters of mercury, already on nifedipine and bendrofluozide, renal function moderately impaired. We've done an echo, only very mild reduction in the ejection fraction, disproportionate to the severity of heart failure. I was working at the time with Sir Professor Patrick Vallance, Her Majesty's Government Chief Scientific Advisor, next to Boris Johnson on the various TV channels we see these days. And we decided not to give the patient an ACE inhibitor. It's already on a diuretic. Instead of looking at the heart, we decided to look at the kidneys. And you can see here a single kidney on the left, that is the right kidney, with severe osteal disease and post-stenotic dilatation. If you give this patient an ACE inhibitor, the patient is going to have end-stage renal failure requiring dialysis because of the reduction in the afferent arterioles, causing reduction in the pressure across the renal artery. And that's essentially an emergency. Unless you thrombolize or go straight for angioplasty, the patient will join the end-stage renal failure program. So what did we do? Let's go for the next slide, George. We decided, instead of giving the patient any more medication, is to go for an angioplasty to the proximal renal artery. The line in the middle is pre and post angioplasty. The patient had constant sodium intake. Those days we were able to control the sodium intake in the diet. And following the angioplasty, there was a significant drop in blood pressure, the top panel, showing a significant from 190 down to 120, a significant reduction in weight within a few days, 6 kilograms in a day or two, reduction in the ANP, plasma atrial natriuretic platelet, we'll discuss this shortly, and also a massive diuresis. This was essentially the cause of the congestive cardiac failure. This is essentially what the human model of the one kidney, one clip gallbladder hypertension in rats. We have published this, the next slide, please. We have published this in the Lancet as a new syndrome of renal artery stenosis masquerading as congestive cardiac failure, together with Professor Graham McGregor, an authority on salt and hypertension, Tim Buckingham, a world-renowned vascular invasive radiologist, and of course, Sir Professor Patrick Vallance. And I'm really grateful to all this. Then we decided to look at the heart. From the Framingham study, we knew that left ventricular hypertrophy was the most important determinant of cardiovascular disease in hypertensive patients. And up until 1995, the left ventricular hypertrophy was measured using M-mode echocardiography. For those not familiar with echocardiography, let me take you through it. It's the panel on the left. We take a cut through the heart and we measure the septum, the posterior wall, and the internal dimensions in systole and diastole, and use a particular formula to measure what we call the left ventricular mass, the weight of the heart, uniformly in all the patients. We said this is nonsense. It cannot work like this. So what we decided to do is to look at MRI, magnetic resonance imaging, and you can see the panel on the right, taking multiple slices, 1 centimeter, tracing every single slide, and then subtracting the internal diameter, and we're finding the true weight of the heart. And what we have shown quite clearly is that echocardiography is inherently unreliable to measure the left ventricular mass. As the more the left ventricular mass, the more the overestimation. We published our data in Australia a few years later. Let's go for the next slide, please. This is an important observation that we did. These are patients with untreated congestive cardiac failure. We know that the heart is not only an elaborate mechanical pump with elaborate valves and the electrical system, but also an endocrine organ. And what this secretes mainly is ANP and BNP. BNP does not stand for British National Party. It stands for brain natriuretic peptide. First identified in porcine brain, subsequently in the heart, secreted from the atria in normal physiology and from the ventricle in disease. All these patients present with severe heart failure. And on the horizontal axis, we have stage 4. These all the patients come in with severe heart failure. And we're talking about very rare to find. They used to call me after midnight to go and do the blood test and do the echo on the patient, because it's quite important to get this patient as clean as possible. And what we have shown is that plasma BNP and ANP are elevated in proportion to severity of heart failure and the 11 ventricular dimensions, and treatment, of course, reduced the level. So BNP was an important determinant of heart failure and also on response to treatment. This hormone is the one implicated in the Entresto, the neurolysin inhibitor, whereabouts the plasma BNP is inhibited from being degraded. BNP causes vasodilation and natriuresis. That's why it's called natriuretic peptide. But the first time we have shown that the BNP suppresses the plasma renin activity. If you look at the panel on the right, the top figure is plasma renin activity. The dotted line is the normal. All patients had normal plasma renin activity. So the BNP suppresses the renin activity, preventing vasoconstriction, preventing further sodium and water retention. So this was an important observation we did. And also it helped in establishing later on the new medication for heart failure called Entresto, which I will come back to later on. If I can have my next slide, please. Together with late Professor Paul Wilson, we looked at the role of anemia in congestive cardiac failure, and we have demonstrated that patients with iron deficiency, with or without anemia, benefit from, as far as the symptoms are concerned, the LV performance if they're given intravenous iron therapy. And this is now the standard treatment worldwide, the ferric heart failure study, on patients with iron deficiency anemia, defined as transferrin saturation of less than 20% or serum ferritin less than 100. So very important. We had a lot of prizes from this study as well. If I can have my next slide, please. Up until 1986, management of congestive cardiac failure was uniformly unrewarding. Mortality of the patients with stage 4 heart failure within a year was approximately 60%. So 6 out of 10 patients coming in with severe heart failure died within a year. And this prognosis was worse than cancer. And then, of course, came the ACE inhibitors, then came the beta blockers, then came spironolactone as well. This is the last in the armamentarium, and this is what we call Entresto and the sacubitril/valsartan combination. The sacubitril it essentially prevents the degradation of BNP, increases BNP level. Valsartan, of course, acts on the renin-angiotensin system. And we have in this study demonstrated that patients with non-ischemic or dilated cardiomyopathy appear to be benefiting more. And we have put this down to the absence of left ventricular scarring and fibrosis. So Entresto is good for more for the non-ischemic rather than ischemic cardiomyopathy. If I can have my next slide. And then COVID came with no funding whatsoever, or funding a shade above zero, and blessed with a fantastic group of junior doctors on the grounds, on the shop floor. We did a number of important investigations, including vitamin D, in situ pulmonary thrombosis, atypical presentation, mechanism of hypertension, the role of procalcitonin, encephalitis, atypical presentation with the machine learning model, and of course, a relative protection from antiviral treatment in HIV patients. I'll take this in a case, please. If I can have my next slide. We were among the first to establish the link between vitamin D deficiency and adverse outcomes in older hospitalized patients with COVID-19. This was an important observation. If you have vitamin D deficiency, you're more likely to have activation of the inflammatory markers. Also, you're more likely to require non-invasive ventilation on HDU, high dependency unit. And usually the patients did a lot worse. This has stimulated a lot of research in the field, and we're confident that this observation is correct. And now it's a standard treatment when patients are admitted to a hospital to be given vitamin D on admission once the vitamin D level has been measured. Of course, the recovery trial was started, has produced positive results with dexamethasone, and we restudied the same population following the use of dexamethasone, and we found that the vitamin D deficiency had no relation to outcome in this situation. So dexamethasone is protective in patients with vitamin D deficiency. My next slide, if I may. It's during the first phase of the pandemic, we analyzed CT-PAs, that is a CT pulmonary angiogram, of all P-positive patients. And we've observed that areas of thrombosis correlated to areas of opacification. None of these patients had DVT. And the inference is that localized inflammatory reaction predisposes to what we have coined for the first time, in situ pulmonary thrombosis. So this is an immune-mediated pulmonary thrombosis. Can I have my next slide, please? What happens to the renin-angiotensin system in COVID-19? A number of important clinical observations. We have noticed that in some patients they have hypokalemia, hypernatremia with new onset of severe hypertension. Furthermore, there was increase in urinary potassium excretion, as well as low aldosterone and low renin activity. And these were reversed specifically by the drug amiloride. The amiloride blocks specifically the sodium pump in the distal nephron. And we postulated that the binding of COVID-19 to the ACE gene, angiotensin converting enzyme gene, dysregulated the sodium channel, causing the above potential life-threatening complications. So hypokalemia, hypernatremia, increased urinary potassium loss, and hyporeninism and hypoaldosteronism, very important observation. And these patients should be essentially looked at and treated with amiloride to prevent any sequelae, because patients are already taking medication, and if the potassium is not corrected, life-threatening ventricular fibrillation and the arrhythmias can result. If I can have my next slide, please. So this essentially has become an important public health message as well. If I can go to my next slide as well, if I could. Our observations in Berkshire included older adults. And what we have noticed, these patients had atypical symptoms. In particular, they presented with delirium, falls, malaise, and lassitude before they had any significant symptoms of COVID-19, in particular fever, cough, etc., loss of taste, etc. And these patients did a lot worse. They subsequently developed COVID-19, and this was an important message, because asymptomatic or atypical presentation can lead to the spread of COVID-19. And we knew nosocomial infection was rampant in a hospital. We had a huge number of patients. And this has led us to essentially go and create a model. If I can have the next slide. Development of a model for using simple biochemical and hematological markers of detecting atypical and asymptomatic patients with COVID-19 with an accuracy of over 80%. And this has joined the armamentarium of other diagnostic tests in COVID-19 and was used widely in ATRAS and TRAS nearby. So it's an important research tool. and also machine learning algorithm to detect atypical and asymptomatic present patients with COVID-19. We also detected that COVID-19 affects the brain. The infiltrates can cause encephalitis, a neuroautoimmune phenomenon like Miller-Fisher and Guillain-Barré. And in this particular situation, we detected that COVID-19 affects the area postrema, which is the vomiting center. The patients can have metabolic disturbances and symptoms and signs in keeping with varicose encephalopathy. This is essentially potentially reversible by giving the necessary vitamins, etc. So it's an important observation, and patients presenting with encephalitis, we should all watch out for the varicose encephalopathy and the other sequelae that may result. The next slide, please. I would like to thank every one of you for listening. It was a very busy presentation, this one, with a lot of information.